Okay, hi there. Welcome to module 1 of this course. So we will start with this is the module plan as I have shown before in my introduction as well, but we are going to start with module number 1 where we establish a clear or practical understanding of what AI actually means in healthcare organizations. So this module is about building your leadership fluency, and the objective here is not to turn into a data scientist. We are here to equip you with the judgment needed to navigate the AI decisions effectively. You will learn to ask the right questions and evaluate AI's true impact. So, this is about bridging the gap between AI's technical potential and its practical application in healthcare. So, we have all seen the nod along trap in AI discussions where leaders approve the pilots without even a clear framework. This leads to wasted resources and missed opportunities. This module solves that problem by giving you the baseline to lead AI decisions with clarity. So, we are moving from deferring to leading, ensuring every AI investment is strategic and well understood. We'll explore how to avoid these pitfalls and make informed choices. So, before anything else, let's just clarify what actually AI means in healthcare. It's fundamentally a prediction system, not a robot. AI is software that uses data to predict or to classify or decide, but it always requires human design, human data, and human governance. Remember, AI is only as good as the data and the workflow it operates with it. Predictions are probabilities, not certainties, and that's a crucial distinction for the leaders to grasp. That this understanding sets the stage for our next discussion on the different levels of AI. So, what actually AI means in healthcare? AI is not autonomous or intelligent in the human sense. It is a software that analyzes the data and makes predictions and also at times executes the task. This process is fairly straightforward. We start with human data, such as the medical records and imaging or operational data. The system then performs pattern recognition, learning patterns from the data. Based on those patterns, it produces a prediction, which is essentially a probability, not a certainty. And finally, the most important step, humans act on that predictions within a workflow. So the real value of AI comes not just from the model, but how it fits into the clinical or operational workflow. So, building on the definition, AI operates across a practical spectrum with three distinct levels. So we have got a rule-based AI, which is highly transparent but less flexible, like medication dosage alerts. Then there is machine learning, the core of modern operational AI, which learns patterns from data, such as sepsis early warning systems. Finally, generative AI, which is what we are hearing a lot these days. This creates new content like clinical note drafting and represents emerging and high potential applications. Understanding these categories is vital because each level carries a different governance risk, which we are going to explore further when we discuss tools versus the embedded systems. Now, let's distinguish between AI as a tool and AI as an embedded system. When AI acts as a tool, it is on demand. A clinician queries it when needed, and a human can easily override it if it is wrong. This typically demands lower governance. However, an embedded system runs automatically in the background, subtly influencing decisions in real time. This kind of AI demands high governance because if this is wrong, it can take a long time for anyone to notice. This distinction is critical for assessing the risk and ensuring the proper oversight. So, to lead effectively, you need a common language. So, this vocabulary isn't about becoming a data scientist, it's about gaining the leadership fluency. So, we are moving from beyond the idea of a tool to understand the core components of AI. An algorithm is a recipe, but the model is the actual dish which is served. Training data is crucial. It teaches the model what to look for. And remember, a prediction is a probability, not a certainty. Automation means the AI acts on that prediction without human intervention. Ultimately, performance tells us how well the model works in the real world. So, understanding these terms help you cut through the technical jargon and ask the right questions. Now, let's look at where AI is being actually applied in healthcare. So, first is operations, which is the most mature space for AI in today. These include use cases like scheduling, no show prediction, staffing, and revenue cycle optimization. Interestingly, most failures here are not because the model is bad, but because of workflow and governance gap. The second is clinical AI, such as the medical imaging, risk prediction, decision support. Here, you will often see FDA clearance or strong research evidence, but that still doesn't guarantee the tool will fit your organization's workflow. And the third bucket here is a population health, where AI can support screening prioritization, disease surveillance, and resource allocation. These systems have enormous potential, but they also come with higher governance and equity considerations. So let's see where is AI is making the tangible impact. This is what we just learned about operations is where AI truly lives right now, offering immediate measurable value. And some of the typical use cases like AI can predict no shows and optimize the capacity for a hospital. For staffing, it can be used for forecasting bed management and improves the emergency department workflow. In the revenue cycle, AI can predict the denials and automates the workflows like authorizations. And in supply chain, it optimizes inventory and procurement. These are mature applications. They are really ready for your leadership oversight. Now we'll explore a little bit of AI's role in clinical settings. While operations offer clear wins, clinical AI presents a more nuanced picture. We have moved from the foundational vocabulary to practical applications. So, medical imaging has the strongest evidence base with FDA cleared products for radiology. Decision support, like drug interaction alerts, is also well established, often through rule based workflows. However, emerging areas like risk stratification for sepsis or readmission show sort of variable evidence. Generative AI for node drafting is also being widely used these days. Remember, FDA clearance is important, but this does not guarantee seamless integration into your local workflow. We need to assess these very carefully. Now, we'll talk a little bit about AI's impact on the population health. So, from clinical applications, we turn now to population health, where AI can scale both benefit and risk. AI helps prioritize screening, identifying high risk patients for proactive outreach. It also aids in disease surveillance, detecting patterns and syndromic data. It supports resource allocation, targeting preventive interventions more effectively. But here is a critical caution: population AI scales both benefit and bias. A biased model can negatively impact an entire demographic. This means high stakes AI demands high demand governance. And this brings to our first major misconception about AI. So this slide shows what I call as a governance burden scale. On one end, you have individual AI tools, for example, a tool using a single patient interaction. If it underperforms, the impact is local. On the other hand, are population level models such as the screening prioritization or risk stratification. Here, if the model is wrong, it can affect the entire group of patients, which means the governance responsibility becomes much higher. So many believe that AI is solely an IT problem. This is simply not true. AI is fundamentally a governance and operations problem that IT supports. IT cannot own accountability for that outcomes. Every AI initiative needs an operational sponsor, and that sponsor is you. You must drive the strategic direction and ensure accountability. This isn't about technical expertise. It is about leadership and judgment. Next, we'll address another misconception, which is blindly trusting the vendor claims. We often assume that vendor claims are absolute, but that's a dangerous misconception. The reality is, when vendor claims are only true for their specific test conditions, not necessarily for your unique environment. You must challenge these claims by asking where, on whom, and when the validation occurred. This critical thinking ensures you are not blindly trusting the results that may not transfer to your population. This leads us to other common misconceptions we may need to discuss. Building on the idea of challenging assumptions, let's tackle two more misconceptions: the replacement versus risk. The myth that AI will replace clinicians distracts from the real danger: over reliance on AI eroding crucial clinical judgment. Similarly, the fear of moving too slowly often overshadows the greater risk of a poorly governed AI deployment. Remember, speed is a competitive variable, but governance is a safety variable. Now, let's put some of these concepts into practice with some real world scenarios. So, we are moving into our first case track, focusing on a scheduling AI evaluation in a regional health system. So, here a 400-bedded hospital is looking at an AI solution promising a 30% reduction in no shows. As a senior operations manager, your role is to evaluate the AI's appropriateness, challenge the vendor evidence, anticipate the potential failure modes, and design a robust governance structure. You will apply the principles we have discussed through all five modules. And also, there is a second one, and which is a public health use case. Our second case track involves an AI driven disease screening for colorectal cancer risk within a provincial public health unit. This is a high stakes clinical context with a pilot budget already allocated. As a program manager, you will assess the data readiness, evaluate the evidence, and navigate integration challenges and define crucial equity indicators. Both of these case tracks will help us ground our theoretical discussions, whatever I'm telling throughout the course, into a practical application that you can use it right away. These cases will be our guiding threads as we summarize this module. So, we have covered a lot in the first module and giving you a solid foundation. You now have a working definition of AI as prediction, not as sentience, and a practical vocabulary for executive conversations. We also replaced four common misconceptions with leadership reframes, equipping you with a more nuanced perspective. Now that you understand what AI is, the critical next step is deciding when your organization should actually pursue it. Leadership judgment has the most leverage in that when decision, which we are going to explore further in module number two. All right, thank you for your attention so far. We will continue this in the next lecture.